Hello, everyone. I'm Dr. Bill Schaffner. On behalf of CME Outfitters, I'd like to welcome and thank you for joining us for episode 3 of the 3-part CME OCast series on best practices for implementing a shingles program in your practice setting. Today's episode will address implementing a shingles protocol in specialty settings. This activity is brought to you by CME Outfitters, an accredited provider of continuing education for clinicians worldwide. As I mentioned, I'm William Schaffner, Professor of Preventive Medicine and Infectious Diseases at the Vanderbilt University School of Medicine in Nashville, Tennessee. I'm pleased to be joined today by my colleague and friend, Dr. Paul Auwaerter. Paul is the Cheryl Lynn and Ken Fisher Professor of Medicine and Clinical Director of the Division of Infectious Diseases at the Johns Hopkins University School of Medicine in Baltimore, Maryland. Welcome, Paul.
Yeah, thank you, Bill. Delighted to be here.
To frame today's episode, let's start by reviewing our learning objective, which is to develop best practices to implement a shingles protocol in specialty practice settings. So, Paul, let's start with a discussion about the incidence of shingles, who's at risk, and the most notable complications of this disease.
Yeah, as an infectious diseases physician, when I see my patients and ask about shingles, or they ask me, about a third of people will experience it in their lifetime if they hadn't received the varicella vaccine. And of course, there's this age gradient, right? The older you are, and especially in subspecialty practices, you're usually seeing a sicker population. They have health problems already. Perhaps they're receiving immunosuppressive therapy, and that all places them at increased risk for developing shingles. So, I think many people are well aware of the potential complications that can be quite severe, not only the pain syndrome, but cranial nerve palsies and even disseminated disease, especially that might afflict some of our patients in our populations that we see in the clinic and in the hospital.
So you mentioned, Paul, some of the key complications of shingles, but what do we know about these complications across different age groups, as well as the impact on hospitalization? There isn't that much impact on mortality, but this disease can make an awful lot of people sick.
Sure. Yeah. I mean, I think, we've all had patients where they are just they become bedbound. They're not capable of performing their daily living and so on. And they may have focal neurologic complications or something as a result of disseminated disease, but more frequently what happens is people are just so incapacitated that they can't perform, they can't go to work, or they can't take care of themselves even, just because of the severity of the pain syndrome. So this is something that I think is very important. And of course, as you get older, all these potential complications also increase, including hospitalizations for some of the issues, such as if you have eye involvement or central nervous system changes.
Paul, postherpetic neuralgia, post-shingles pain, is probably the most feared symptom of shingles. So what should clinicians know about PHN?
Yeah, so many people have looked at postherpetic neuralgia, and research studies have sometimes defined it as either 3 months or 6 months after zoster. But in reality, I think of it as occurring and having to do something for patients 3 to 4 weeks if they have persisting pain. Some of the hallmarks are, the severity of pain either before the rash or with the rash is often a very reasonable predictor for postherpetic neuralgia. And it's higher in older age groups, or if you have comorbidities. Studies have suggested that up to 10 to 18% of people might be afflicted by this. And it's indeed debilitating and requires a fair number of strategies to try to deal with this.
Yeah, so given the burden imposed by shingles and postherpetic neuralgia, it's fortunate that we have some vaccines available. Tell us about those.
Yeah, so there are now 2 vaccines FDA approved. The one that we started off using, I believe, back in 2006 was a live attenuated vaccine. And that live attenuated vaccine was FDA approved for over 50, but the ACIP only suggested using it in people over 60, in part because the protection seemed to be greatest the first 3 to 5 years after receiving the vaccine, and that was a single dose. And it didn't work that well in older people. So people over 70 especially didn't look like they reacted as well as those who are 50. And then about 3 years ago, a new vaccine was approved, a recombinant vaccine that also had a novel immune adjuvant and gave very good immune responses. It's not a live vaccine. This was, though, a 2-dose administration over a 6-month time frame, and was given by intramuscular injection. But the real performance benefits were that even in older age groups, this gave lovely immune responses. And we now know up to about 4 years of fairly good protection against the onset of developing zoster.
So great. 2 good vaccines, but now the recombinant vaccine is the one that has been recommended by the Advisory Committee on Immunization Practices. And it's my impression that the live attenuated vaccine actually is no longer being presented to the market. Is that correct, Paul?
I believe the manufacturer has ceased making it, so there may be some supply that could be employed if clinicians sought to use it. But functionally, I think the recombinant vaccine has been the most popular one. As anyone that's dealt with trying to obtain one know, it's often been challenging to get, in part because manufacturing's been a bit difficult. The immune adjuvant, it comes from a special soap bark tree that's native to Chile, and that's not always has been available, but it's increasingly so at this stage. So I think a lot of those earlier barriers are not nearly as problematic, Bill.
Yeah, so give us some practical tips then about how we should actually use this vaccine.
Yeah, so I think the first is always to identify patients that would benefit from it. And even in our specialty practice, I'd have to say when it first came out, it was released as a drug, not as a vaccine. So it meant that in a Medicare situation, it was covered under the Group D benefit. Mm-hmm. And so unless if you were a pharmacy in your office, you really couldn't administer it for reimbursement, and it was sort of cumbersome. What's happened over more recently, I think, is that more and more even commercial insurers and Group D are, of course, all covering it, depending on their benefits. So it's always worthwhile to try to explore that before understanding. But importantly, pharmacists in many states now administer it as well.
Yeah, and given that the recommendation of the ACIP is that all immunocompetent people receive it starting at age 50, and so many people have medical insurance that covers it readily, doctors can do it in their own practice, between 50 and age 65, because before those difficulties with Medicare and Part D come up. So start early. But I don't think we're always taking advantage of visits to the doctor's office. So, Paul, there are still missed opportunities to vaccinate. And so tell us a little bit about how we can assess in a specialty practice these opportunities to bring this shingles vaccine to our patients for their benefit.
Yeah, I think, Bill, that's really important. I think that the missed opportunities are first just to bring it up. And if you're seeing someone longitudinally, a lot of times I feel people turn to the subspecialist as an expert, and just mentioning that you should get the shingles vaccine, I think, is probably the first step, recognizing whether they have had it or not, and then making that strong recommendation is key. Now, I think a lot of people say, well, I already got the shingles vaccine, I don't need it. But the reality is, even if you got the live attenuated one, you're going to benefit from the shingles vaccine. And so most people would say you really don't have to rush it until 5 years or so after you've gotten the original zoster vaccine, but you could probably even get it earlier if you happen to have received it even less than 5 years ago. So I think those are some of the things I tend to think about. And then there's some practical aspects that we'll get to, but it's pretty clear that if you look at subspecialty practices overall, there's a lot of missed opportunities. Either it's people don't bring it up, they don't have vaccine protocols, or they don't stock it in their offices. So obviously, if you have something on hand, that's a great opportunity to go ahead and administer the first dose at that time.
Yeah, I always remind docs that the recommendation of the ACIP for immunocompetent patients is to start at age 50. And so between age 50 and 65, most of your patients are going to have medical insurance that covers zoster vaccine. Beyond age 65, Medicare, you get into those difficulties with Part D and reimbursement. But you can do an awful lot of good by administering this vaccine between age 50 and 65.
Yeah, I think there's a lot of this lingering confusion about reimbursement for the shingles vaccine. And Bill, as you point out, people that are not in Medicare, a lot of private and commercial insurers now, that especially under ACA or the Obamacare, do cover this as part of their insurance plan. So that's a great opportunity. And even for patients over 65 in Medicare, you do have to check the Group D status. But importantly, pharmacists in so many states can administer it, since it is a drug benefit, and not be a worry. But that strong recommendation from the subspecialist still carries, I think, a lot of weight in those circumstances.
So do you have a few tips, particularly for those in specialty practice, to implement a shingles protocol in their offices?
Yeah, and Bill, it's not only shingles, of course, there are other vaccines as well. So, if you're a subspecialist and not doing anything, and we know this, for example, cardiology and flu, if you get a flu shot, your risk for cardiovascular disease goes down. And so we have a lot of experience, I think, where having immunizations in the office with a subspecialist leads to improved health outcomes. So the first is just to consider having that in your office. And if you don't have vaccines, the CDC has a lovely toolbox kit to really help implement some of these practices. And then even if you do have vaccines in your office, it's important to have some kind of reminder system. An EMR prompt is one that we have in our practice, for example. The other thing which I always emphasize is, if your staff administers it, educate your staff. I can't tell you how many people go up to the clerk or our nursing assistant, say, "Do you think I should get that vaccine?" And they'll be like, "Yeah, I don't know," or "No." So you want to tell those people about the benefits, because can't tell you how many people are actually derailed by that conversation.
Boy, those are great tips. Thank you, Paul, for providing us with a great discussion on best practices to implement a shingles protocol in specialty practice. So now, let's close with our SMART goals. That is, specific, measurable, attainable, relevant, and timely goals. These are what we hope healthcare providers listening today will take away from this podcast.
So, Bill, I think these are fairly straightforward, and there's three of them. The first is, you want to recommend shingles vaccine to any at-risk patient in your specialty practice. I'll mention as an aside, there aren't still yet formal recommendations for people that are immune suppressed, but likely those will be forthcoming. And at least in renal transplant patients, appears safe. Second, incorporate the best practices for administering this. So this would be some of the protocols we talked about, the EMR, and other strategies that you can find in that toolkit with the links on this podcast. The third would be to counsel patients about the burden of shingles and really help address their concerns, tell them how effective it is, and that there's really not much in the way of any serious adverse reactions. Most people, of course, just complain about the local pain. I just got mine a few weeks ago. Yeah, it's sore, but it goes away in 2 or 3 days and responds to acetaminophen or nonsteroidal. So the three are: recommend, incorporate best practices, and then address your patient concerns and tell them why they should get the vaccine.
Paul, that's terrific. This has been a great discussion. Thanks so much.
Thanks, Bill, and it was great going over this information. I hope it's helpful for your practices.
So everyone, to receive CME CE credit, click on the link identified here to complete the post-test and the evaluation online. So thank you all for joining us today for episode 3 of our three-part CMEOCast series. To view additional episodes on best practices for implementing a shingles protocol in primary care settings or in pharmacies, please visit CMEOutfitters.com. Thank you again for participating. Thank you for providing the best care for your patients. And please, everyone, stay safe and vaccinate.